Good afternoon, and thank you all for standing by. This is the conference coordinator. All lines will be placed on listen only until we're ready for the question and answer session of today's call. This call is also being recorded. If you have any objections, please disconnect at this time. I would now like to introduce your speaker, Dr. Martin Ruiz Beltran. You may begin, sir. Thank you.
Thank you so very much. Good afternoon, everybody, and thank you once again for joining us to another presentation from HRSA. My name is Dr. Martin Ruiz Beltran, and I am a Senior Public Health Analyst with the Office of Quality and Data in the Bureau of Primary Healthcare here with HRSA. We're very pleased that you have made some time out of your busy schedules to join us in this very important audio conference. Today's presentation is the third one on a series of risk management audio conferences designed to assist you and to support your operations. As a result of your feedback, we continue to providing you with the state-of-the-art technical assistance and guidance on issues pertaining to quality, accreditation, and risk management, such as our risk management sponsor website and our continuing education learning module. Today's presentation, titled Internal Event Reporting, an essential tool for risk management and patient safety, is yet another resource that we offer to you. This risk management internal reporting tool is not a mandatory one, and we are not requiring that you use the same format or language on the development of your own internal event reporting process. What we hope is that you, with this tool, and with this presentation, we can assist you to enhance and or add to the quality and thoroughness of your current risk management and patient safety initiatives. At this point, I would like to introduce to you once again our partners from the Keystone Peer Review Organization, also known as KIPRO, and our expert partners from the ECRI Institute, who are going to lead us in today's presentations. We at HRSA are very pleased to have some of the leading experts in the field partnering with us as we look forward to continue offering you best practices and up-to-date resources. Without any further delay, I'd like to introduce Ms. Amy Goldberg-Alberts from the ECRI Institute. Amy is one of the experts on ECRI and is the risk management supervisor for the program that we have here in HRSA. So thank you once again for joining us. And Amy, please take it away.
Thank you, Dr. Ruiz Beltran, and thank you, everyone, for attending. We see from our registration list that many of you have attended past audio conferences, but for some of you, this is the first one that you're attending. So let me begin by introducing KIPRO and ECRI Institute to you, for those who do not know us already. A quality improvement and care management organization founded in 1985 and headquartered in Harrisburg, Pennsylvania, KIPRO selected ECRI Institute to provide you free clinical risk management resources. KIPRO works with HRSA on medical malpractice claims reviews and risk management services under a contract initiated in 2004 and provides risk management and patient safety technical assistance to Section 330 FTCA-deemed health centers and free clinics. ECRI Institute, as noted on the next slide in your handout, is an independent nonprofit applied research institute which over the past 4 decades has helped thousands of healthcare organizations across the nation develop patient safety, healthcare quality, and risk management programs to improve patient care. Our approximately 300-person staff is made up of physicians, nurses, patient safety, risk management and quality professionals, and others. We're an evidence-based practice center designated by the U.S. Agency for Healthcare Research and Quality. We're a World Health Organization collaborating center for patient safety, risk management, and healthcare technology, and we're a federally designated patient safety organization. Over half of all HRSA grantee organizations throughout the country have now activated their user IDs and have set up passwords so that they can access the full suite of clinical risk management services that are being made available by ECRI to you free on behalf of HRSA. This website contains risk management guidance articles, sample policies and procedures, risk assessment tools, educational courses with continuing education credit attached, and other resources to make your jobs easier so that you can learn from others and also so that you can customize to your own organization's needs and not have to reinvent the wheel. You can read about all of the resources offered, and you can log in from the website that's printed on that slide, but I will read it as well. It's www.ecri.org/clinical_RM_program. User IDs were sent to executive directors, risk managers, and chief medical officers at all HRSA Section 330 grantee organizations. But keep in mind that an unlimited number of individuals at your organization can obtain their own user IDs to access the materials. If you've not yet activated your user ID, do please email us and we will resend the instructions to you. Our email address, also printed on that slide number 3 in your handout, is clinical_RM_program@ecri.org. With your audio conference registration confirmation, you received an email link to the slide handout and to the Event Reporting Toolkit resources. We hope that you've had the opportunity to print or download the handout and maybe even to look over the toolkit materials, although we will be going through each of these toolkit resources with you today. Throughout this audio conference, we will refer to slide or page numbers in the handout so that you can follow along. This is the third in a series of Brown Bag Lunch audio conferences, all of which are archived on the website if you happen to have missed them live. About a month after each audio conference, we also post it as an e-learning course within the learning management system with continuing education credit available. So I also encourage you to take the course and obtain a certificate and credit. At this point, I'm going to turn the program over to Kathy Shostak. For those of you on our previous audio conferences, you already are familiar with Kathy's experience in ambulatory care risk management. She is a nurse with 20 years of experience in healthcare risk management, the most recent of which have been focused on patient safety and medical error prevention. Kathy has risk management consultative experience within the medical malpractice insurance industry and management experience at the corporate risk management level of a large multi-specialty physician group. Ms. Shostak serves as ECRI Institute's Chief Risk Management and Patient Safety Liaison to the HRSA-funded health centers and free clinics. So with that, I hand it over to Kathy to lead you through the essentials of internal event reporting.
Thank you, Amy, and welcome, everyone. We'll begin on slide 4, where you'll see the objectives for today's audio conference. The intent of this program is to review the importance of internal event reporting and present approaches to implementing an effective reporting system. This includes strategies for communication and learning from events and near misses with the intent of preventing recurrence, reducing risk, and improving patient safety. The program is not intended to cover external reporting, such as when an accredited ambulatory care organization reports a sentinel event to the Joint Commission, or when a health center reports an adverse occurrence to an outside agency, such as a state health department or patient safety organization. I will refer to the model policy, the sample documents, and other tools available in the Event Reporting Toolkit on the Clinical Risk Management website. So if you have not downloaded those materials, you may want to do that following the program. For ease of downloading, it's best to right-click on the documents and choose Save As to save them right to your own computer. By saving this way, you can also customize the tools to meet specific needs of your organization. In a few minutes, we'll briefly review all the items in the toolkit. New items that have been added to the toolkit include an event summary tool for incident trending and reporting, and a sample action plan template for documenting and tracking identified problems. So please check back to be sure you have downloaded the additional items. We want to make it clear that the samples and policies included in the Event Reporting Toolkit are intended as guidance to be adapted consistent with the internal needs of your organization. These policies and tools are not to be viewed as required by ECRI Institute, KeyPro, or the Health Resources and Services Administration. Toward the end, we'll open up the program for comments and questions, and we hope you'll contribute your experiences with event reporting in your health center or clinic. On slide 5, we begin with the central question: why report events and near misses? What's the point of collecting and analyzing this type of information? And on slide 6, the answer is that you cannot manage what you don't know about. Healthcare organizations use adverse event and near-miss reporting as a means of identifying problem areas and potential problem areas so as to improve systems and processes in providing healthcare services. For example, if delays in receiving results of diagnostic tests in the clinic are not reported, the problem is apt to continue and likely to affect the timeliness and appropriateness of patient care. Data on the frequency and types of test result delays can be crucial to determining how to reduce delays, correct reporting problems, and improve test result communication systems. Immediate notice of the occurrence of an event can also support loss reduction activities in terms of disclosure communication, appropriate medical care, and early resolution of a potential liability claim. Early notice really can make an impact. In my own past experience as risk manager for a large medical group, receiving a phone call followed by an event report for an inadvertent arterial puncture by our phlebotomist allowed for immediate medical intervention, full explanation and apology to the patient, and implementation of absorption of costs for the patient's care associated with the puncture event. Had we not taken these steps, the patient may have initiated a liability claim alleging harm due to negligence. Moving to slide 7, some specific reasons why health centers and clinics should report events and near misses are listed. Remember, risk management practices are designed to reduce the frequency and severity of adverse events in terms of human harm and financial loss. Risk management practices are implemented through risk identification, prevention, and reduction. Data obtained from analyzing reports is a primary source of information for patient safety improvements as well. The importance of event reporting in the detection of unsafe systems and in tracking trends over time is recognized as key to clinical risk management, spurred on by a number of factors, including recognition that the collection of near-miss reports should also be included as part of event reporting systems in order to detect system weaknesses before serious harm occurs. Recent enhancements in reporting systems' abilities to analyze event data, reports of improvements in patient care that were made as a result of events and near misses being reported. One improvement made as a result of a near-miss reporting is a well-known case of patient wristband color inconsistency. A nurse who worked in 2 different health facilities was unaware that the facilities used different wristband colors to denote that the patient had a do not resuscitate order in place. As a result, she almost did not resuscitate a patient because of the color wristband he was wearing. After the near miss was reported, the facilities worked to standardize the meaning and designation of patient wristbands. Other factors promoting event reporting as key to clinical risk management include establishment of the various accreditation standards, including requirements for systems to identify and correct practices or processes that can lead to unsafe care. Event reporting that leads to correction and improvement also supports meeting the national patient safety goals for ambulatory care. It is important to clearly define what should be reported, and everyone in your health center should understand what and how to report. On slide 8, key definitions taken from the model internal event reporting policy from the toolkit are listed here, and we've added the Joint Commission definition of a sentinel event. Now I'd like to review the documents contained in the event reporting toolkit available at the Clinical Risk Management website. And so on slide 9 is a screenshot of the toolkit. It is important to establish policies and procedures for reporting. One of the main documents in the Event Reporting Toolkit is a model policy to assist you with policy and procedure development or enhancement and system implementation. The Model Internal Event Reporting Policy, while not mandated or required, is meant to serve as a model for you to adapt for the needs for your health center or clinic. On slide 10 is the next item in the toolkit. Event Reporting Barriers and Suggested Strategies is a document that contains tested advice on how to overcome barriers to reporting in your organization. A lack of reporting does not mean that events are not occurring. Providers and staff must not only understand the value of reporting, they really have to feel it. Providing feedback on safety improvements or solutions to problems identified through event reporting is the #1 way to overcome barriers regarding staff's reluctance to report because they're not hearing about positive changes coming about as a result of their reports. An event involving misidentification of a patient in the clinic where I previously worked exemplifies this. A medical office assistant reported that the wrong patient had been sent to our clinic by a rehab facility. The patient had periods of confusion and limited mobility and thus was transported by ambulance. The assistant discovered the error by following established procedures of asking the patient to state her name and checking her ID band. Although the transport crew had the correct patient's transfer papers, they had the wrong patient. By reporting the incident, our assistant was an integral part of evaluating our own access, scheduling, and registration procedures to proactively determine if and how a similar error could occur and to improve the process. Our CEO personally thanked the assistant and highlighted the positive effect of her report in our clinic newsletter. Moving to slide 11, tracking and trending of events by type, frequency, and severity helps to prioritize risk management and patient safety efforts. This process is automated when using an electronic or web-based event reporting system that permits aggregation and analysis of event data over time. The development of a statistical database of reported events can provide important management tools for risk prevention, risk reduction, and patient safety activities that are specific and measurable. Increasingly, computerized risk management information systems and commercially available software are being used to report, track, and find trends in events and claims. Automated reporting systems can facilitate timely and concise reporting, prioritization, and follow-up of events, as well as providing on-demand customizable trend reports for management use. Many systems can also identify sentinel events that require root cause analysis and specified events that may be statutorily reportable. In addition, performance information gained through data collection can compare internal historical performance with external performance information, such as comparison with other organizations or with best practices when available. Another option is to develop a tool using a simple spreadsheet or relational database software. Slide 11 is showing the event report summary tool using an Excel spreadsheet that's available in the Event Reporting Toolkit. The sample tool has pre-programmed macros that calculate rates of specific events by quarter. And on slide 12, you'll see a graph that was generated by the tool once the numbers of events and patient encounter data had been entered. Like the other tools at the Clinical Risk Management website, you can further customize the spreadsheet to meet your health center's particular needs. Moving on to slide 13, the flow of information diagram from the toolkit seen here demonstrates one way that event information can be communicated and acted upon. Usually when an event occurs or is discovered, the risk manager is notified and a report is completed. At the point of care, medical intervention is provided to the person involved, and whenever possible, the occurrence should be communicated to the patient with an explanation of how it will be managed, and follow-up care is provided as needed. In the flow diagram, this is shown under the box supervisor or department head. If, for example, the event is that a significantly abnormal test result, let's use the example of an elevated prostate-specific antigen level, on a patient's subsequent visit to the clinic, the result was found not to have been reported to the primary care provider. A series of interventions would be needed. At the patient level, the test result would need to be discussed with the patient along with recommendations for additional testing, possibly consultation and referral, and so forth. Also, the provider should communicate the delay surrounding the result and whether it has any impact or implications for treatment. At the health center level, the event warrants review and investigation. The cause of the failure to report the abnormal PSA should be analyzed, particularly because the potential for patient harm could be severe. An index for assigning a severity level to events, including near-miss and no-harm events, is included in the model event reporting policy. A root cause analysis should be conducted for all events with a high severity. In the flow of information diagram, this is shown in the box under Risk and Quality Management. In the example of the failure to report the significantly abnormal test result, the outcome and findings of a root cause analysis would be used to improve the process for receiving and communicating abnormal test results to reduce the probability of the occurrence of future related events. We'll touch on root cause analysis tools and resources in a few minutes. Overall, it is important that you consider best communication processes and action steps for handling events and event reports for your center or clinic. Slide 14 is the National Coordinating Council and Medication Error Prevention algorithm that has been adapted for events beyond medication errors. Not going into depth here, but the algorithm displays the severity index provided in the model policy in a graphic that you can refer to for illustration purposes. On slide 15 is a copy of the sample data collection report from the Event Reporting Toolkit. Certain elements should be incorporated into the form used to report events, regardless of whether the form is paper or electronic. Although many healthcare organizations have embraced computerized reporting, paper-based reporting forms should not be entirely discounted as ineffective. A portable paper-based tool may identify medical errors and unintended events not captured through a standardized electronic event report. The challenge comes with paper forms in how to aggregate data for trending purposes, and thus the information provided on paper forms must then be entered into some type of a database to facilitate analysis over time. The data collected should facilitate compilation of critical information for risk response, also creation of reports for clinicians, management, the governing board, or other appropriate groups. Report forms should be structured so that both clinical and non-clinical information can be reported easily. Slide 16 displays a portion of the sample event report narrative form from the toolkit. Typical event report forms, whether paper or electronic, contain demographic information on the individual involved in the event, a brief narrative description of the event, and checkboxes for classifying the event by type and category. Event reports can be supplemented with a follow-up report that contains more detailed information, such as contributing factors and a corrective action. Recommended content and information for event reports is detailed in the Model Event Reporting Policy. The information is also listed on slides 17 and 18 for your review. Event report forms should include a statement that the event report is confidential and should not be filed in the patient's chart. Reports should be retained for a minimum of 2 years or for the usual and customary statute of limitations. All reports of events involving minors should be maintained until 1 year past the age of majority. Moving on to slide 19, another item in the toolkit, the sample response and action plan template, can be used to document your health center or clinic's plan to address risk management or patient safety issues identified through the event reporting or other risk identification systems. An improvement plan should outline the actions to be taken to improve the systems, the processes, or structural issues that are related to the root cause of the event. At this point on slide 20, we pause to consider event reporting in the broader context of quality improvement and patient safety, and I'm going to hand the program back to Amy.
Thank you, Kathy. If you participated in our earlier program on developing a risk management plan, you may recall this slide that depicts the overlapping functions of risk and quality in patient safety. Analysis of adverse and sentinel events and trends is one of those overlapping functions. Analyzing near-miss incidents contributes to proactive risk assessments, whereby potentially harmful errors and adverse events can be prevented through system redesign, staff education, and other means. I don't need to read all of the intersecting functions that are depicted in this slide. Keep in mind, though, the key concept is that risks are identified through many means, and for that reason, a reporting system should be robust enough so as to also capture unsafe occurrences, hazardous conditions, and really any situation that could lead to patient harm and malpractice liability. Quality measures, performance indicators, patient complaints, and competency evaluations are all other sources of information for risk identification. Several other ways of discovering events other than event reporting itself are listed on slide 21. One of these other methods of identifying and trending adverse events in the primary care clinic setting is the use of safety indicators or trigger tools. This method involves auditing a sample of patient charts for indicators of harm or triggers, which are identifiable specific items that indicate that an adverse event may have occurred. Triggers can be based on common causes found in malpractice claims data. Examples of triggers include new diagnoses of cancer, nursing home placement, or use of more than 5 medications. You can link to the Institute for Healthcare Improvement Outpatient Adverse Event Trigger Tool on the IHI, that's the Institute for Healthcare Improvement website, at the address given on this slide. A 6-step approach for implementing or improving event reporting processes is listed on slide 22. Over the next series of slides, we'll walk through this suggested approach that includes setting goals, creating a fair and a just culture, evaluating current systems and possible new event reporting systems, whether paper or electronic, and implementing and monitoring the process for effectiveness in risk identification. On slide 23, providers and health center managers should establish agreed-upon goals for the event reporting process. The goals should reflect the intended outcome of the system in terms of collecting and compiling information, analyzing data, communicating trends, and providing management tools for preventing events and implementing procedural and system improvements. On slide 24, the support of senior leaders and clinical providers is necessary to promote a just culture. That's a culture in which open communication prevails in a non-punitive environment that is conducive to reporting events without the fear of reprisal. A just culture, one that embraces fair-minded treatment and creates effective structures that help people reveal their errors and help the organization learn from these errors, does not mean one that is not accountable, nor does it mean an avoidance of critique or assessment of competence. If the culture of an organization is not conducive to reporting, the system will not be successful and under-reporting will be very likely. Therefore, event reporting systems must allow the ease of reporting for staff, must be viewed as a positive contribution, and show evidence of resulting change and improvement. As Kathy previously mentioned, staff need meaningful feedback on how the information that the reports that they do submit is used and whether any changes are made as a result of them submitting a report. We talked in greater depth about the concept of a just culture at an earlier audio conference that was entitled Clinical Risk Management Basics. That was our first audio conference of this year in March. The audio conference held at that time has now been archived on the Clinical Risk Management website, as well as in the Learning Management System for continuing education credit. And so we encourage you to go to the website, re-listen to the audio conference, maybe have others on your staff listen, and also, if you haven't taken the course yet, you can obtain continuing education credits for it. Slide 25 lists just a few helpful questions for assessing an event reporting system. an assessment of any existing event reporting system should be undertaken to determine not only whether it's effective in capturing information on actual events and near misses, but just as important, how effective is the system in contributing to the improvement of systems and processes. So event reporting really is a quality improvement tool. If the existing event reporting system is not providing the information needed to identify problem areas, analyze event trends, and make improvements, it's time to consider revamping or replacing the system. One approach to accomplishing this is similar to other project management initiatives and is shown on slide 26. A committee or a task force comprising key clinical and management staff, including the risk manager, should be formed to establish desired criteria for an event reporting system. Collecting and comparing information on available systems is the most time-consuming aspect, but well worth the effort to ensure that you have the information that you need to select a system. Event reporting systems have evolved from standalone software to web-based systems with many options and features. A needs analysis and user surveys can reveal much about what type of event reporting system will work best for you. If you're thinking about a computerized system, which most systems are now, key considerations will center on your health center's information technology capabilities and the computer literacy of providers and staff. Moving to slide 27, we really could devote an entire program on the selection and implementation of an event reporting system, but basically, if your team has considered the features and services of available systems and you've identified a system that will meet the needs of your organization, then cost and ease of implementation will most likely be the determining factors. Implementation is generally accomplished through a work plan timeline and involves focused staff education and training that emphasizes that reporting is intended to support learning, not punishment. The implementation process is highly dependent on whether paper-based event report forms will be used and forwarded to a central data entry point, usually the risk manager, or whether decentralized direct data entry of events will be by individual providers and staff, possibly in multiple locations. If yours is a multi-site organization, you might want to investigate whether the system has the ability to aggregate data across all of your locations. Reporting errors in primary care typically involves the prescribing of medication errors, laboratory test results, file system mistakes, drug dispensing events, and handling of abnormal laboratory results. Slide 28 reviews some internal event reporting system benefits. It's important that each clinic clearly defines situations that constitute clinical or non-clinical events or near misses that it wishes to be reported. Further educational programs should give providers and staff a clear understanding of what to report and specifically how to report it, while stressing that everyone is responsible for reporting events. Some examples of reportable events that may occur in a health center or clinic setting include a clinical emergency that arises unexpectedly, communication issues among providers or between providers and patients that adversely affects or even has the potential to adversely affect patient care, patient complaints that you receive that are of a serious nature, diagnostic test problems such as omitted or delayed tests or results or lost specimens, documentation issues including information not documented for a patient encounter or ambiguous notes that don't support the patient's diagnosis or the patient's treatment plan, handoff or referral problems such as an inability to secure specialty care or the lack of follow-up by a consultant, tests or procedures performed on the wrong patient, medication errors, missed appointments or no-shows, scheduling or access problems, and skill, knowledge, or competency problems among staff. By using an event reporting form that includes categories and event types, that are pertinent to clinic and primary care settings, health centers can act on significant events and identify trends that lead to quality, risk, and safety problems. How a primary care practice studied the use of event reporting to identify problem areas and target them for improvement is described in one of the guidance articles that's on the Clinical Risk Management website. That guidance article is titled Patient Safety and Risk Management. The practices study that's described in this article found that scheduling problems, missing charts, and patient dissatisfaction were the most frequently reported events, prompting providers and staff to focus on enhancing access, shoring up medical record filing systems, and improving the patient's experience of care in the practice. I encourage you to access and read this guidance article. Again, it's on the Clinical Risk Management website. With that, I'm going to hand the program back over to Kathy, who will share her own experience in selecting an internal event reporting system.
Thank you, Amy. I just wanted to share my experience going through an RFP process with the medical group for a full risk management information system. Some of the criteria we use when evaluating systems centered on reputation of the vendor, but also on the comprehensiveness of the system, the support services in terms of IT support and staff training, ease of use of the system, and compatibility of our existing information systems. With regards to applicability to our offices and clinics, the pertinence of the standard classifications of event types in the system, as well as the ability to customize event types to meet the unique reporting needs of both primary care and specialty services was considered, along with costs, of course. On slide 29, we now turn to event investigation. Criteria for conducting an event investigation are outlined in the Model Event Reporting Policy. Investigations are generally performed for an adverse event with a high severity or potential high severity. For example, any event that may have contributed to or caused temporary or permanent harm or death. Also, serious events involving the transfer of a patient to an emergency department or an inpatient facility. The goals of event investigation are to determine what happened and why, or to fill in the gaps in information, and to recommend or implement corrective actions and preventive measures. It's a fact-finding, not a fault-finding mission. It should take place as soon as possible while the information is fresh. For serious events, using the index in the model policy, that would be category F and above, it is best to involve legal counsel up front and notify the liability insurer in accordance with established notification procedures. If equipment is involved in an event, it's best to impound, inspect the equipment, and save all packaging or disposables, and to gather any inspection or repair records. For interviews, it's best to interview those involved or in the event or a witness to the event, including the patient when possible. When interviewing, interview one at a time and individually in order to corroborate details in the sequence of events. You will find an event investigation tip sheet included in the guidance article, Safety and Risk Management, at the Clinical Risk Management website. Interview notes are not entered into the patient's medical record. They're considered quality improvement materials. Documentation of the serious event follow-up should also be treated confidentiality and not be included in the medical record. On slide 30, notations to make in the patient's chart are listed. Documentation about the event in the medical record should not reflect that an event report was completed. On slide 31, root cause analysis questions and resources are listed. Common methods for root cause analysis include the fishbone diagram, the 5 whys, fault tree analysis, and event and causal factors analysis. Remember, a root cause is one of typically several basic causes that lead to failure in a process that, if eliminated, would prevent or minimize the adverse effects of the failure. Root cause analysis is the most basic type of event investigation. It's an analytical approach to problem solving that seeks to identify why adverse events happen and how to prevent them. A number of tools and templates are available to assist in performing root cause analyses. 2 resources for root cause analysis materials are listed here on slide 32. Reviewing the process for root cause analysis could be the topic for a future audio conference, and we welcome your feedback for future planning. High-level steps for proactive systems analysis, such as the failure mode and effects analysis, are listed on slide 32. Failure mode and effects analysis seeks to identify and proactively correct potential failures in high-risk processes. A common high-risk process in primary care is one that we've already mentioned today, the diagnostic testing process. Using failure mode and effects analysis, your team would map out the process and then identify where errors are most likely to occur in managing laboratory and imaging tests in your health center. An assessment of the management of abnormal test results could reveal problems with, for example, pap smears, mammograms, INRs, PSAs, and others. Failure modes might be identified in specimen tracking, in referrals, and in use of follow-up logs. Priorities would be assigned to failures with the most potentially serious effects on patient care. Redesign strategies could include improved logging systems, implementing audits to track testing and referrals, and documentation of follow-up care. On slide 33, some failure mode and effects analysis resources are listed. These are available online. FMEA may be another topic for a future education program, and again, we welcome your feedback about that. Moving to slide 34, implementing solutions to identified problems involve determining the activities that are critical to implementation, such as the process redesign and education and training. Determining the resources needed, both human and technology, and the time frame for overall implementation. This can be established in a work plan that includes the major milestones and completion dates, also the responsible individuals for each action. The sample response and action plan template reviewed earlier is a tool that can help with this process. Identifying potential impediments will help with the development of strategies or countermeasures to the impediments to change and improvements. Communication throughout the process is critical to keep staff engaged, as noted on slide 35. Key to implementing any change or improvement is ongoing communication, monitoring, and feedback. This can be in the form of education about lessons learned, dissemination of periodic safety alerts, and training on system modifications. It's important to celebrate successes and to reward providers and staff for positive contributions. One new resource designed to assist providers to comply with the state of Minnesota Adverse Healthcare Event Reporting Law is the Minnesota Adverse Event Measurement Guide. The guide outlines the process of setting up and implementing measurement plans. It guides team decision-making related to measurement and advises on how to evaluate the success of an action plan based on measurement results. While this was designed for a specific state, you may find the general concepts and guidance available in the guide helpful in your health center. The link to the measurement guide is available on slide 35. On slide 36 is an example of how reporting an event can help to change and improve a situation in a clinic or a health center. A clinic nurse was involved in a medication error. She had a client who needed adult hepatitis B vaccine. She removed the vial from its carton, read the vial label, and proceeded to draw up the vaccine to be administered. Only when she was doing data entry after administration of the vaccine did she realize that she had given an adult hepatitis A vaccine. She noticed the error based on the lot number, which was different than previously documented hepatitis B lot numbers. The nurse reported the error, and an investigation was done. The clinic stocked GlaxoSmithKline adult hepatitis B vaccine and Merck adult hepatitis A vaccine. Both vials have orange caps and covers, which may have contributed to the mix-up. However, during staff interviews, it was discovered that a different nurse had removed a vial of hepatitis A vaccine from the manufacturer's carton and then, not needing it, had apparently put it back in an empty hepatitis B vaccine carton. The nurse knew that the label stated hepatitis A, but due to confirmation bias, she still read hepatitis B because that was what she was expecting it to be. The clinic designed the following solution to the problem. To help avoid mix-ups, the clinic decided to remove vials from their cartons prior to storage. Also, the policy was changed to require the nurse or other clinician to document the vaccine, including lot number, on the vaccine form or log just prior to administration, but not to document the actual drug administration until after the vaccine had been given. The rationale was that recognizing a major difference in lot number format from what is normally recorded could help in recognizing that the wrong product is in hand. The clinic also started involving a family member to assist in the double check process whenever possible. We're going to open up the lines for questions in just a moment, but right now I'm going to turn it back to the operator to conduct our polling question. Operator?
Thank you. We will now conduct the polling question. Our question is, how many parties are in the room with you? I will repeat the question. How many parties are in the room with you? Please press star 1 for 1, star 2 for 2, star 3 for 3, star 4 for 4, star 5 for 5, star 6 for 6, star 7 for 7, star 8 for 8, and star 9 for over 9. One moment, please.
Slide 37 is just a reminder that the Clinical Risk Management website contains these guides, articles, standards, and guidelines, which are also many resources, also education and training materials, and numerous web resources to help you develop and implement your event reporting systems. If you haven't activated your login and password to the Clinical Risk Management site, contact us and we'll resend your user ID to you by email. If you have already activated your ID and you are the delegated access manager for your organization, remember you can provide unlimited access to individuals in your health center. The website address to log in is www.ecri.org/clinical_RM_program. The dedicated telephone number is 610-825-6000, extension 5200. And the email address is clinical_RM_program@ecri.org. The very last slide in the handout for the program also lists this contact information. Operator, you can now open up the line for any comments and questions.
Thank you. At this time, we're ready to begin the question and answer session. If you would like to ask a question, please press star 1. Please unmute your phone and record your name clearly when prompted. Your name is required to introduce your question. Press star 1 and record your name, please, to ask a question. And one moment for the first question. Our first question comes from Ms. Menninger. Your line is open.
Yes. During the presentation, you read off a listing of examples of occurrences that would be reported. Where could I find that list?
Sure. That list it's actually not printed on the handout.
You'll find very similar, if you download the event summary tool that we've included in the Event Reporting Toolkit, you'll find similar, if not exact, listing in that tool. But that's a modifiable tool, so that, in other words, you can add the types of events that you want for your particular health center or clinic, to that list. That's a suggested list of things that are commonly problematic in primary care.
Okay, thank you.
I also might mention that we had a similar question at one of the other audio conferences that we held this week, and that question had to do with why report things that are not actually accidents, but rather they're indicators of what might potentially happen in the future. So we certainly do recommend that you encourage your staff to report not only accidents per se, but things like missed appointments, no-shows, access problems, and the like, because like I say, they could be indicators of a larger underlying problem.
Thank you, ma'am. Were you finished with your question?
Yes, ma'am. Thank you.
Thank you. Our next question comes from Dentia Cardenas. Your line is open.
Hi, this is Cynthia Cardenas. With your documentation, did you say that you keep it for 2 years and then 1 year after the minor reaches a particular age? Did I understand that right?
Yes, that's what we would recommend in general terms for an event report itself. We generally say to maintain those for 2 years. And for minors, of course, 1 year beyond the age of majority. There may be specific requirements for your specific state, and so you'd have to determine whether those apply as well.
And may I also ask, what do we do with this information that we're keeping? Do we report it to the government in some way?
No, this is for your own internal risk and quality purposes.
Okay. All right. Thank you very much.
Welcome.
Thank you. Our next question comes from Emily Stalsman.
Hello. Yeah, I had learned about the IHI trigger tool. Lydia, can you mute your phone? I'm sorry. We have two lines here. I learned about the IHI trigger tool, and I believe the criteria are all for patients over 65, and I'm wondering if you have if there's additional items for patients under 65 for the trigger tool.
The trigger tool that I referred to is for ambulatory settings.
Mm-hmm.
So I guess I would just check to see if that's the case for the ambulatory setting trigger tool, that it's for only over 65. That was not my impression.
Okay, maybe I'm thinking of a different one. Thank you.
Yeah, IHI does have several different trigger tools available.
Excellent. Thanks.
They do have a specific one for ambulatory care.
And that's for patients of all ages?
I believe so.
Okay.
Great.
Thank you, ma'am. At this time, I'm showing no further questions. As a reminder, if you'd like to ask a question, please press *1, unmute your phone, and record your name. One moment. Our next question comes from Cynthia Cardenas.
Hi. You had stated that no documentation should go into the medical records. At what point should it go into the medical records?
That recommendation was not that you shouldn't document in the medical record. What you would not indicate in the patient record is that you've completed an event report.
I see. Okay.
That particular statement, event report completed, should not appear in the patient's record. You would document in the patient's record the facts surrounding any type of event that occurred involving the patient. The recommendations that we have are on slide 30 in your handout for what should be documented in the patient's record.
Great. Thank you very much.
You're welcome. Thank you for clarifying that.
Thank you, ma'am. At this time, I'm showing no further questions.
Okay, Dr. Ruiz-Beltran, would you like to make any closing remarks?
Yes, thank you very much. And once again, I'm very pleased to have this type of audio conferences. It demonstrates the quality of services that ECRI and KIPRO are providing to all of our grantees. If we don't have any further comments or questions, I'd like to conclude today's presentation by thanking you once again. Have a wonderful afternoon.
Thank you. That does conclude today's conference call. Thank you all for joining. You may disconnect at this time. One moment.